Patella instability is a multifactorial diffusion. The stability of the patellofemoral jaw depends on static dynamic factors within of static of the bone anatomy, soft tissues on the axis of the limb, and within the anatomy to the quadriceps.
Patellofemoral syndrome is a very common entity. It's probably the most common overuse condition that we see in the knee. And generally people present with what we refer to as anterior knee-related pain, which is pain in the front of the knee. If we were to look at the design of the knee, there are basically three bones. There's your femur, which is your thigh bone, the tibia, which is your shin bone, and then there's the patella, which is the kneecap. So with physical activity, the patella is pulled up and down and up and down, up and down as we run. And if the kneecap stays in the middle of that groove, it's pulled up and down without any problem. If the kneecap is deviated to one side or the other, the cartilage on the back of the kneecap tends to get inflamed. The back of the kneecap is a perfectly white, smooth, shiny surface. If you look inside the knee joint, it looks like a cue ball. It's absolutely beautiful. The end of the thigh bone has that same material. In patellofemoral syndrome, people's kneecap are aligned one way or the other, so they're bearing weight primarily on one part of the kneecap than the other. So if they do a lot of repetitive activity, one part of the kneecap is working overtime and the other part of the kneecap is taking the day off. And essentially we'll start to develop an inflammation behind the patella and inflammation on the end of the thigh bone. If they have a flat foot, we'll often put them in an arch support to neutralize the alignment of the foot. More than anything, it's really a matter of retoning their quadricep. There are four muscles that control your kneecap. There's one muscle on the inside, one muscle on the outside. The muscle on the outside is generally a little bit too tight, and the muscle on the inside is a little bit weak or atrophic. If we can strengthen the muscle on the inside of the knee and work on the flexibility in the muscle on the outside of the knee, we can kind of balance that kneecap, allow that kneecap to ride in the groove that it's supposed to, and the inflammation will go away. So part of it's rehab. You know, acutely when they have pain, icing is important. Acutely an anti-inflammatory like Advil or ibuprofen is often helpful. But in the long term, if they want to be involved in an exercise program, it really involves balancing the mechanics of their knee and it involves optimizing the alignment of their foot. If they continue to be active, because one part of the kneecap is bearing more weight than it should, we will see some breakdown of that articular cartilage on the back of the patella, and we will see potentially the development of arthritis down the road, where that white, smooth, shiny surface wears away. So it is important to get it treated, and not only to lead an active lifestyle, but also to prevent arthritis. In some cases, we do surgical intervention. It's not common, but I would probably say 1 out of 50 or 1 out of 100 people, we might end up doing an arthroscopy and smoothing down the back of the kneecap, or we might end up doing a procedure to manually reposition the kneecap so that the kneecap will in fact stay in the middle of the groove.
Patellofemoral pain syndrome is a term used to describe pain in the form of the knee around the kneecap or knee bone. It's a sustained calm runners, knee jumpers, because it's common in people who participate in sport, especially women and young adults, but patellofemoral pain syndrome can occur in people who are no athletes as well.
In a properly aligned knee, ligaments and tendons attached to the tibia and the quadriceps hold the patella as it glides comfortably in the femoral groove. Force between the patella and the femur is evenly distributed on the surface of the femoral groove. Most important in assuring proper patellar alignment in the femoral groove is the balance between the soft tissues, principally the muscle called the VMO and the lateral retinaculum. Imbalance between these tissues usually causes one of two principal types of malalignment, patellar tilt or lateral glide. Both conditions involve a weak VMO and a tight lateral retinaculum. Left untreated, the condition worsens, causing a lateral soft tissue contracture with a corresponding weak VMO. Hence, the patella is effectively locked out of its normal tracking position. Two main problems result from this abnormal positioning of the patella. First, Force between the patella and the femur is now shifted and concentrated onto a smaller area of the lateral condyle of the femur. That increased pressure transfers into the nerve-rich subchondral bone, creating pain. Second, the lack of contact on the medial articular cartilage will cause chondromalacia, or a softening of the cartilage. To decrease pain, greater surface contact area must be restored in the joint. To correct the malaligned patella, balance must be restored by strengthening the VMO and stretching the lateral retinaculum. The Q-lock reduces pain by increasing the joint surface contact area and realigns the patella by using traction to stretch the lateral tissues. As the brace is pulled on, the compression of the closed patella sleeve helps reseat the patella in the femoral groove. The patella traction strap is then applied and provides medial tension and anterior pressure to further guide the patella into its correct position. With greater patella surface contact in the femoral groove, pain is decreased and normal knee function begins to be restored. The brace's unique ability to provide both anterior and medial tension make it the most effective in relieving patellofemoral pain, particularly in cases involving patellar tilt. Long-term correction is achieved as the calibrated patella traction strap is periodically tightened, putting medial traction on the patella. This pain and stress-relieving traction on the patella will aid in the quality of a quad strengthening program by improving patellofemoral function. With a consistent exercise and stretching program, combined with using the Q-lock patella traction brace, pain is reduced and normal function is restored.
Risk factors for patellofemoral pain syndrome activities such as running, squatting, and climbing up and down stairs, dynamic valgus, increased patella maltracking, forceps for anatomy is version prone. Over unsafe increased physical activity level, patellar instability, and quadricep weakness. Studies. The affection of the patellofemoral joints on Norways more and more frequent. According to Colvin, the evidence acute patellar dislocation is between 5. 8 and 29 patients per 1 million inhabitants, and its incidence increases the advanced age. The recurrence rate after a second dislocation is 50%. Diagnosis. For diagnosis of patellofemoral instability, it is necessary with addition to a thorough clinical examination imaging support, either by simple radiographic interference projection and computer-assisted tomography and nuclear magnetic resonance.
In this video, I'm going to give a description of what patellofemoral pain syndrome is and if and how we can diagnose it. Hi and welcome back to Physio Tutors. Patellofemoral pain syndrome, or PFPS, typically refers to anterior knee pain usually occurring during activities such as running, squatting, or walking up and down stairs. Patients of all age categories are affected, and the condition can persist for multiple years in up to 60% of cases. So what is causing the pain? Loading of the patellofemoral joint during weight-bearing activities on a flexed knee is thought to be altered due to various reasons, leading to pain. One hypothesis is abnormal patellofemoral joint alignment and morphology of the trochlea. Consequently, the patella can't track smoothly up and down, which over time can cause irritation of the joint surfaces and trigger nociception. Secondly, muscle weakness of the quadriceps and glutes is a potential risk factor associated with PFPS. This is because poor strength and function in the quads will influence how the patella tracks in the trochlea and how load is distributed across the patellofemoral joint. Weak glutes, on the other hand, can alter the lag axis if the femur adopts a more internally rotated position with regards to the tibia, again impairing smooth movement of the patella within the femoral trochlea. On our channel you will find proposed diagnostic clusters for PFPS, but all of them only demonstrate weak clinical value. You can find the clusters by clicking the info icon in the top right corner. Essentially, Asking a patient whether they have anterior knee pain while squatting is the best available test to date, as PFPS will be evident in 80% of people with this finding. But PFPS has to be seen as a diagnosis of exclusion, meaning the diagnosis is formed after all other possible pathologies have been excluded. Alright, I just mentioned that you'll diagnose PFPS only after excluding other pathologies, so be sure to check out our knee assessment playlist on the left. A collection of all tests, including evidence and description, can be found in our assessment ebook. Check the first link in the video description or click the icon in the bottom left corner of the screen for more info. Before you leave, make sure you are subscribed to our channel and check out our other social media pages. This was Andreas for Physio Tutors. Thank you for watching and I'll see you next time. Bye.
Orthopedic test. The patient should via sub-standing, sitting and letting down is important to detect sling rotational miscellaneous indisocial, such as union valgus, abdominal cube angle, recurvatum, intratation, tibial, extraction, and tetral. James is necessary the evaluation, the muscle trophies and well arranged, and motion of the knee and joint, capitation and emny. The similar maneuvers assign the stability of patella on trochlea and well laxity of the medial stabilizer and rigidity of the lateral stabilizer. Apprehension test with 20 to 30 grains inflection as the makes to move the patella lateral maneuver impossible when patient feels sensation. The patella is going dislocate and prevent going ahead with the maneuver. Patellar tilt. With the new full station, the patella engraves in medial and later in normal situation the lateral border, and patella can elevate above horizontal. The impossibility and exhibiting detail about tense lateral structure tours. Patella tracking. With a precision set on stretcher and the neck and neck raised, they are and the brain is to full station with vision to flex in aging. When it reaches 20 to 30 grams, a bone produces a patella index and the path for vision of the location at sub-elevation in full station to reduce pulsation in the trochlea.
Hello everyone, this is Paul from Ortho Eval Pal, and with me I have Shane. Shane is 42 years old and has been having chronic knee pain. He's had it for quite a long time, right? Yeah. And it flared up when you had this little episode where you kind of did a little sprint, try to get some cover from the rain, and had some pain, especially around the lateral aspect of the patella. And it's really been bothering you ever since, right?
Yep.
And what do you like to do for hobbies?
Hiking, camping, all that. Get outside.
Yeah. And talk to me about like hiking. Do you have a problem on level surfaces?
Not usually, no. It's when I'm going up or going down, hiking the mountain or whatnot, coming back down. I get knee pain on both sides here, so.
Okay. So, a lot of deceleration, and it's usually associated with some sort of activity where your foot's on the floor, correct?
Yeah.
Okay. So, just for the sake of time, I'm going to get right into the video. He's had right into the evaluation. He's had no episodes of giving way, no instability. He used to play baseball and was a catcher for how many years?
20.
20 years of being in a squatted position for a long period of time, which has probably contributed to this, okay? So we need to kind of remember that. I'm going to start off with a physical exam, and then I'm going to have him do some functional squatting, and then we'll talk about the treatment, okay? So let's have you lie right down, Shane, if you would. So the first thing I do is I check to see if he has any warmth to the knee, and there really isn't, okay, on the left compared to the right, maybe a tad bit. The next thing I do is a brush test to identify if he has an effusion, and he does not, okay, that's negative. I'm curious, he points to his pain as being on the outside of the knee here, so there are many sources of discomfort on the outside of the knee. I'm going to try to rule out the meniscus, okay, so I give him hyperextension, he has no pain with that. I take him to full flexion, he has no pain with that, so full flexion would cause him posterior meniscal horn discomfort. Extension would cause anterior horn discomfort, and he doesn't have any of that. He has no tenderness to the tibial tubercle, no tenderness to the patella tendon. Prepatellar bursa, not painful. Okay. I'm going to check his medial capsule. Medial collateral, no instability and no pain. Lateral capsule, lateral collateral, no instability and no pain there. Okay, I'm going to check his ACL, do a quick Lockman, so I need you to really relax, let that leg be real heavy. And I have a nice little end point right there. And he has a negative sag sign, nothing going on there. Alright, so when we start poking around here, we get to this lateral side of his knee. So we're going to check his IT band. So I'm going to place my finger right on the femoral condyle. I'm going to flex him and extend him, and I don't feel anything snapping there. He has no pain with that. There's no pain to palpate. There's no joint line tenderness. There. So we're starting to think, what is going on with this guy, okay? So I'm going to do a little patella grind or Clark sign. So I want you to, I'm going to hold his patella down just lightly. Don't do this really hard because that can be very painful. And I'm going to have you tighten up that muscle for me slowly.
Yeah.
Any pain with that?
No.
Okay, so no pain with that. But now what I'm going to do is I'm going to start to palpate around his kneecap. There's no tenderness to the medial side of the kneecap. His plica, which is right here, is non-painful. And so I'm going to go to the lateral side to find that he's very tender right there.
Yep.
Okay, he doesn't like that at all. Now, if I take it, if I go above it and I push his kneecap inward, how painful is that?
Yeah, not bad, but I can feel it.
There's some discomfort there from stretching the lateral retinaculum here. But when I palpate the lateral side of the patella and the lateral femoral condyle, that's very painful right there. You can see how he jumps. So he has signs of lateral patella compression syndrome. Now, if I take his kneecap, try to push it inward, I'm really not getting a good glide here. Okay, so I'm really thinking this is more of a patellofemoral dysfunction, lateral patella compression syndrome. I'm going to ask him to stand for me, and we're going to watch him squat now. And this will give us some idea of functionally how he's looking. So I want you to keep your feet, your shoulder width apart, okay? And I want you to go ahead and give me a squat. And you're going to notice that his feet collapse, his knees start to go into a little bit of valgus, increasing that Q angle and increasing that lateral patella compression here. So I'm going to have you go back up for me, and I'm going to have you do it again one more time. And back up. Okay, now let's try it with just one leg. So try it with this one.
Okay.
And you'll notice that as he bears weight just with one leg, he collapses even more.
Yep.
Okay? And he doesn't really have good strength there. So what we're going to do, and you can have a seat back here, Shane. What we're going to do with him is we're going to try to take care of some of the biomechanics with an orthotic on this side because he has a pes planus foot. We're going to increase the flexibility of the IT band, which we tested before the video. So he's very tight in the IT band, very tight in the hamstrings, and extremely tight in the gastrosoleus complex, which is why he has this really poor functional squat. We are going to work on re-educating that quad muscle to fire up better so that it holds his patella in the groove better. I'm going to mobilize his patella, and I'm also going to put him into an orthotic just to help hold him up. And when we do his squatting activities, we're going to put him on a wedge so that we lift the medial side a little bit just to keep his patellofemoral joint in better alignment when we're trying to get this to contract. So a hefty home exercise program on flexibility. And we're going to work with him in here on re-strengthening that quad and getting some functional work back. So, folks, if you have any questions about this, please leave a note in our comments section. And, check out our playlist on knee dysfunction. We have multiple knee issues. And if you enjoyed this video, please like it and subscribe to our channel. Thanks.
Treatment. Conservative treatment focus mainly on strengthening the tense lateral structures. They use knee packs, taping, correct posture and gait defense, and finally wax. We consider you most important a correct balance of kinematic change, improving the patient's proprioception in addition to extreme feedback and neuromotor coordination work is necessary. Muscular work at the level of the hips and the pelvis is also important. The rotador imbalance can screen femoral anteversion.
In this video, we are going to look at a lower extremity strengthening protocol for the management of patellofemoral pain syndrome. Hi and welcome back to Physio Tutors. Due to the multifactorial etiology of patellofemoral pain syndrome that we discussed in another video, multiple rehab protocols have been proposed, either focusing on developing quad strength or focusing on strengthening the glutes. Nakagawa from 2008 combined the two components into their rehab program that also included stretching of the hamstrings, quads, calves and ITB, as well as patella self-mobilizations to address all possible contributing biomechanical factors. Their 6-week RCT showed better outcomes for the group that performed additional hip strengthening exercises to the standard quadriceps and stretching protocol. While the exercises are only described in words, we recreated them to the best of our abilities. Alright, I hope you enjoyed this protocol presentation. If you want to watch more from our exercise content, check the playlist on the left and make sure to subscribe to our channel for more regular uploads. We have also recently released our own assessment ebook, which you can check by clicking the icon in the bottom left corner or check the link in the video description. To follow us on other social media, check the links in the video description. And as always, this was Andreas for Physio Tutors. I'll see you next time. Bye.